Today we'll be talking about the Congenital Talipes Equinovarus deformity, otherwise known as the CTEV deformity. This is a very common deformity found in the pediatric population, and I'll be dividing this chapter into two videos, and the first one will cover the basics, and the next one will cover the management and also the post-management programs. Let us start with the basics. So, as we all know that CTEV is a very unique condition and it happens in a very specific population. Epidemiologically, it is a most common birth defect that can be found with a frequency of around 1 in 200 to 1 in 1000 babies born, and it is most frequently found in male rather than female, and half of them are bilateral. By definition, it is actually a deformity that is idiopathic, no known cause for it, but sometimes CTEV can also occur in association with other conditions such as arthrogryposis, other hand anomalies, amniotic band syndrome, and also other conditions that are considered quite rare such as the hemimelia, myelodysplasia, and so on. And gene abnormality has also been found to be connected with CTEV. It has been mentioned that there are 4 major factors which may produce a clubfoot deformity, or also known as CTEV. During the pregnancy period, there could be a polygenic hereditary pattern coming down from the parents, and at the 8th week of development, where the musculoskeletal system is being developed, there could be an arrested development, and during the pregnancy age 20 to 30 weeks, there could be primary muscle abnormality with secondary joint changes, followed by the end pregnancy problems such as intrauterine pressure. These factors can be connected into the conditions of the amniotic fluid, whether or not it is in excessive or it is lacking, such as in oligohydramnion cases. Now, for the idiopathic type of foot deformity, usually it consists of 2 main problems, which is the bony deformity and also the muscle contracture that occurs. One must not view CTEV as a pure muscle problem because it has 2 components in it. There is definitely a bone deformity in CTEV. Let us start there. In CTEV, we could see problems in nearly all bones in the hindfoot. On the talar, we could see that the talar neck is usually medially and plantarly deviated. The navicular and the cuboid is also rotated medially, and the calcaneus is usually in a varus position. This is a very important point because during the course of the treatment, the calcaneus must be corrected to the point where it reaches a valgus position so that it is considered as well enough corrected. If the position is still maintained in a varus position, then it is not corrected well enough. Next would be the muscle contracture. As you can see here that alongside the bony deformity, there are also problems of the muscles which causes the typical deformity that CTEV patient possess, which is the cave, or the C for cavus, A for adductus, V for varus, and E for equinus. And each of these conditions are associated with different activated muscles, such as for the cavus, it is usually caused by the abnormalities in the intrinsics, FHL and FDL. FHL stands for flexor hallucis longus, FDL stands for flexor digitorum longus. And for the forefoot adductus, it is usually caused by abnormalities in the tibialis posterior muscles. Hindfoot varus may be caused by the Achilles, tibialis posterior, and tibialis anterior, while for the hindfoot equinus, it is caused by the Achilles. This table here summarizes very well all those muscles that have been mentioned before, which one was the stronger muscles and which one are the weaker muscles, and will generate the deformity seen in the CAVE deformity seen in CTEV cases. As you can see here, sometimes the deformity may present in a more complex form, such as the equinovarus and supination cases, and it may also present as a equinovalgus or calcaneovalgus. These are not the typical CTEV findings, because these are usually associated with other conditions, and sometimes people may mistaken it for CTEV, but usually the only thing that makes us point out that this is CTEV is that it is generally in equinus and it has a varus component. If it has a valgus component, then generally it definitely is not a CTEV. And then, as you can see here, besides those factors, the etiologic factors itself plays a dominant role in the formation of CTEV, with familial occurrence of around 25%. PITX1 gene, or the transcription factor for limb development, is most likely connected to the CTEV case. And for the classification of this condition itself, generally you could classify this condition into an typical or atypical case. In typical clubfoot, then the clubfoot usually presents without any connected causes. It could be a positional clubfoot, and rarely the deformity is usually very flexible and is thought to be an intrauterine crowding. It could also be a delayed treated clubfoot when it presents beyond 6 months of age. It could also be a recurrent typical clubfoot, which occur whether the original treatment was by Ponseti or by other methods. It could also present as an alternatively treated typical clubfoot. And for the atypical form, usually it is associated with something else. The atypical clubfoot could present as a rigid or resistant atypical clubfoot, which may present as a thin or fat foot, and usually the fat type is more difficult to treat. It could also present as a syndromic clubfoot and is associated with other types of syndromes. It could also be a teratological type, neurogenic type, or even an acquired clubfoot type. Now, after knowing about all of those things, the next thing you really need to get yourself used to is the scoring system, because in every type of clubfoot there are certain severity levels, and you cannot know how severe the clubfoot is without an objective evaluation. I'm going to go over the rather simple one first mentioned by Dimeglio. So in the Dimeglio type, the assessment of the clubfoot through its severity is done in various planes. You could see here there are 4 pictures depicting 4 different types of planes. The first is the sagittal plane evaluation of the equinus component of deformity, the frontal plane which evaluates the varus points of deformity, and then there's the horizontal plane which evaluates the derotation of the calcaneopedal block, and the last would be the horizontal plane which evaluates the forefoot in relation to the hindfoot. Now each of these picture here has a different points. You can see here that the one in red has 4 points of value, and the ones in this turquoise color has a 1 point value. So each time your patient comes to you, you can place them in one of these positions and give them a certain score for each of these 4 pictures. Afterwards, there are also additional parameters that needs to be put on, which is the posterior crease, the medial crease, the cavus, and also the poor muscle condition. If each of these parameters exists, then another point is being added. So the addition of these 4 position plus another parameter gives you a total score which could be classified into this table here. If the total score is around 5 to 10, then it is considered as a moderate deformity. But if it reaches 15 to 20, then it is a very severe deformity. This Dimeglio is good to estimate the probability of a good outcome of a patient at the age of 2 years old. So here you can see the initial Dimeglio numerical severe rating numbers, the ones you get from adding up all those numbers from the chart before. After you plot them inside this chart, then you get an estimated probability. Let's say if the patient has an initial Dimeglio score of 6, then the estimated probability is around what? Let's say 0.99%, 0.99 chance of good outcome probability at the age of 2 years old. So this Dimeglio is very good for forming informed consent to your patient, explaining to them regarding the prognosis. And there is another scoring system that is very useful and very famous out there, which is called the Pirani scoring system. The Pirani scoring system is rather different from the Dimeglio because it divided the foot into a hind foot score and a mid-foot score. And for the hind foot score, it is divided into 3 different types of evaluation, which is the posterior crease, the rigidity equinus, the empty heel. And for the midfoot, it is divided into the curve of the lateral border, the medial crease, and the talar head coverage, with each of these scores scoring from 0 to 1, depending on the severity level. Let's go over to the pictures here. We could see here that the posterior crease or the PC score goes from 0 to 1. When there is 1 or 2 deep creases that is visible at the posterior heel aspect, then we give it a 1 score. And for the empty heel is somewhat subjective, and some people are getting difficult in assigning a score for these points. And this table here actually helps us to determine which score to give. We could see here that if the calcaneus is immediately palpable, we give it a 0 score by pushing in your finger towards the heel of the baby. But if the heel pad feels soft, comparable with the feeling of putting a pressure at the tip of your nose, then it is given a score of 0.5. But in the end, if the heel pad feels very empty, comparable with the feeling of putting a gentle pressure on the ball of the thumb, then it is given a score of 1. The other hindfoot score that is being used is the rigid equinus. You could see here it has a clear demarcation of what degree of equinus is being assigned to what type of score. And the next one would be the midfoot score. Midfoot score also consists of 3 scores, and the first one would be the medial crease. You could see that here that if there is 1 or 2 deep creases, which is appreciable change of the contour of the arch seen at the medial aspect, then it is given a score of 1. Next would be the lateral head of talus. We could say that the main pathology that occur in CTEV comes actually from the talonavicular joint. Since there's an abnormality there, then the talus is actually the center of rotation of the CTEV deformity, and therefore the lateral head of talus is actually palpable in the early case of untreated CTEV. So it is also the same. You could palpate the lateral head and give it a score of 1 if it is still easily palpable. But if there is a reduction of the ability to palpate the lateral head of the talus, then you give it a score of 0.5. And if it is completely not palpable, then you give it a 0 score. The last would be the curvature of the lateral border of the foot. You can see here it is clear that if the lateral border is straight, then the score goes to 0. Now adding up all those scores give you meanings, and those meanings are the ones that help you determine your treatment plan. We will go over the treatment plan based on this Pirani scoring system later on at the next part of this CTEV video. So for the Pirani score, the maximum score will be 6, which means that it's very severe, and 0, which means that it is not severe at all. Now moving on, after you have mastered all these basics regarding the CTEV condition, we will move on to the diagnosis. In order to make a good diagnosis, one must start from the history taking, continuing to the physical examination, and ends up with additional investigation. For the history taking, it is very essential to take a good family history. Family history should include everything starting from the prenatal, natal, and postnatal period, and for the associated conditions that have been mentioned before. For the physical findings, you could see that from the foot itself, the foot will always appear small, smaller than its normal counterparts. We could see here that the right CTEV, even if the patient has completed all the treatment session, the foot is generally smaller than the normal foot. And next would be the crease. The crease could be found at the medial aspect or the posterior aspect of the foot, and the deformity can be found in all parts of the foot. Starting from the hind foot, you could see that there is equinus, and very different from positional foot deformity, because sometimes you get consultations from the pediatric ward that they have a baby born with a CTEV like foot, and they are asking you to evaluate whether or not it is a true CTEV. And a very quick way to assess this kind of deformity is by giving in a dorsiflexion force. If the patient's plantar aspect of the foot, which is this area, when given force from the plantar region, this area could touch the dorsal aspect of the leg or calf, then this position is only a normal variant, and it will gradually correct itself through time. But if the patient's dorsal aspect of the foot cannot touch the anterior aspect of its leg when given this force, then it is definitely an abnormal foot and requires treatment. Now moving on, the varus can also be seen at the hind foot, and for the midfoot you could see that there will be cavus, and there would also be an inversion, which is a complex deformity with a adduction, supination, and plantar flexion component. You could see here that the foot is supinated inwards as opposed to the normally placed foot. For the forefoot itself, you could also see that there are several deformities which include adduction and also plantar flex metatarsal. You could see here that from the plantar view of the patient, you could also see that the first metatarsal here is indeed flexed, and you could see here a very prominent crease over the medial aspect of the foot, which indicates how much the first metatarsal is flexed. And judging from the toe position, you could also see here that since it is flexed, the whole first metatarsal is also deviated inwards. It even falls underneath the second toe here. So the toe position can give out what actually happens in the metatarsal. And next would be assessing the calf. You need to know that the patients with CTEV also presents with a small and short tibia, which gives them an appearance of a slightly smaller calf, as seen here in this patient. This leg here has a CTEV foot that has already been treated, but even as the patient progresses and gets older, the leg never grows to a normal size. And next would be the additional examination. Imaging is usually not required in early CTEV cases because a good history taking and examination will reveal this condition. But you can always take plain radiograph to evaluate the angles of the foot that is being involved that helps you raise this diagnosis, because in plain radiograph you could see here that the foot can be, this is a normal foot, the A, the B is an abnormal foot. You could see here that in CTEV, because there is tight medial structures, the whole foot is derotated medially. You could see here that there will be parallelism of the talus and the calcaneus because of its rotation, as opposed to a normal foot where the talus and the calcaneus is diverged. You could see here that it somehow converges. And also the patient will present with a talocalcaneal less than 20 degree and a negative talus first metatarsal angle, which is represented by angle B here. Normally, the angle should be positive, meaning that the metatarsal is slightly rotated outwards as opposed to the talus. Here, the first metatarsal is rotated inwards as opposed to the talus, giving it a negative angle. Okay, moving on. The view that should be taken in patients with this CTEV is called the Turco view. The Turco view is taken with the foot in a dorsiflex position and is taken from the lateral view. Here we could evaluate the hindfoot parallelism of the talus and calcaneus, such as the one depicted before, and we could also measure the talocalcaneal angle and find it to be less than 35 degrees, and there could also be a flat talar head. As for the AP view, we could find that the kite angle should be less than 20 degree. Kite angle is also known as talocalcaneal angle. Normally it is around 20 to 40, but because of the parallelism of the talus and calcaneus, the angle grows narrower into under 20 degree. Next would be the degree of the talus and the first metatarsal going into negative, which is shown here in this picture earlier. Going outwards is positive and going inwards is negative, and therefore in CTEV there is a negative angle. Okay, next is ultrasound. Ultrasound is usually available if being taken early in pregnancy. In 12 weeks in utero, we could already seen the position of the foot in utero, but you need to know that there is a high false positive rate because a lot of these conditions seen are actually normal variants, and children are frequently born in a normal foot position. That is all for today for the basics and how to diagnose a CTEV. Following the next video of CTEV will cover the management plan and also the post-management plan for the CTEV. Please like and subscribe the Orthopedic Tutor channel for more videos. Thank you.